Hello everyone, my name's Alex Ford. I'm a Professor of Gastroenterology in Leeds, UK, and my area of interest is research into disorders of gut-brain interaction. I'm delighted to have been asked to provide this overview of our group's work, which results from me being awarded the 2020 Aldo Torsoli Award for our work in this field. I've been asked to do this by the Aldo Torsoli Foundation. My interest in functional GI disorders or disorders of gut-brain interaction started around 12 or 13 years ago when we performed a longitudinal follow-up study of individuals from the community who either did or didn't report irritable bowel syndrome type symptoms. We conducted a 10-year follow-up study, which at the time was one of the longest studies that had been published in this field, and we followed people up and asked them whether or not they still had IBS symptoms 10 years later, and you can see that we were able to look at the incidence of IBS over that 10-year period, which was around about 15% in people who did not have symptoms at baseline. And we were also able to look at the prognosis of IBS in those who had symptoms at baseline, and you can see that 2/3 of people still had symptoms 10 years later. From that, we went on to summarize efficacy of various therapies for IBS, and that was done as part of the American College of Gastroenterology's monograph on the management of irritable bowel syndrome. And we studied what would be classed, I guess, as traditional therapies like fiber and antispasmodics and peppermint oil, and I'm going to show you the results of these as forest plots. So these forest plots show individual trials, the results of those, and then a pooled result at the bottom as a relative risk of remaining symptomatic. And if the diamond is to the left of the line of no effect, then that shows a beneficial result of the treatment. And you can see that there were 7 trials of soluble fiber ispigula showing a beneficial effect, and also around about 22 or 23 trials of antispasmodic drugs showing a beneficial effect of that class of drugs, although there was some heterogeneity between individual trials. We looked at that by splitting them into individual drugs, and you can see here this is one of the things that came out of that, which was that hyoscine was a beneficial treatment for IBS. All of the trials showed a beneficial effect. And similarly, peppermint oil, 5 trials, you can see again the relative risk of being symptomatic was reduced with peppermint oil. We also looked at gut-brain neuromodulators, so low-dose antidepressants, and this is probably one of the most cited papers from this work. It's been cited around 400 times. And you can see that tricyclic antidepressant drugs like amitriptyline and desipramine were superior to placebo, and all of these trials showed a beneficial effect, although in some cases this was not statistically significant because they were underpowered. But when you pool the studies together, you can see that there is a reduction in the relative risk of remaining symptomatic, and the number needed to treat here is around about 4. SSRIs were also beneficial, but there's a bit more heterogeneity or noise between studies here. You can see some of these studies are negative, but overall they appeared to be beneficial. We also looked at probiotics. Again, lots of heterogeneity here because of the individual species and strains used, and harder to draw direct inferences from these data. And then finally, we looked at psychological therapies versus a control of either usual management, routine care, or a waiting list, and you can see that cognitive behavioral therapy and gut-directed hypnotherapy were also more effective than a control for treating irritable bowel syndrome. Around this time, we also validated the diagnostic criteria for IBS, so criteria that were used to reach a positive diagnosis and minimize unnecessary investigations. And we summarize these using what are called likelihood ratios. So positive likelihood ratios mean the chance that you've got the disease if you test positive, and negative likelihood ratios mean the chance of not having the disease if you test negative. A good positive likelihood ratio for a diagnostic test positive likelihood ratio would be between 5 and 10, and a good negative likelihood ratio would be less than 0.1. So you can see that the Manning criteria actually perform quite modestly, and this crude statistical scoring system performs better, but it's quite complicated and unsuitable for use in daily clinical practice. At the time that we conducted this study, the Rome criteria had not been validated, and that was something that we addressed later, and I'll come back to that. We also looked at the yield of applying tests for celiac disease in people who sounded as though they had IBS in a meta-analysis, and you can see that the odds of having a positive blood test for celiac disease were almost 3 times higher in people who had suspected IBS and the odds of biopsy proving celiac disease were more than 4 times higher. And this meta-analysis has changed practice in that all guidelines for the management of IBS now recommend that people who sound as though they have symptoms of IBS are screened for celiac disease before that diagnosis is reached. So as I said, we went on to examine the accuracy of all available diagnostic criteria for IBS, including Rome, in a large diagnostic test study that recruited around about 2,000 people with lower GI symptoms undergoing colonoscopy, which was the gold standard to exclude organic disease. And what you can see in this study is that all of the criteria perform very similarly, which is perhaps not unexpected because they're all derived from one another, and that their positive likelihood ratios and negative likelihood ratios are quite modest. We also performed a meta-analysis of population-based studies to estimate the global prevalence of IBS, summarising data from all of these and pooling it in a single meta-analysis, and you can see that overall the prevalence of IBS type symptoms in healthy people in the community was around about 11%. So at any one point in time, 1 in 9 people who are healthy in the general population are reporting IBS type symptoms. This study has had quite a large impact. It's been cited more than 800 times to date. And more recently we've used newer statistical techniques, what's called network meta-analysis, to try to study the relative efficacy of treatments for IBS. So you can't make inferences about relative efficacy of treatments from trial-based meta-analyses because that you're comparing them against a placebo in most trials, not against each other. But network meta-analysis allows you to get around that by making indirect comparisons between each active treatment through the placebo arms of the studies. And you can see that this is the network meta-analysis of what we would class as kind of traditional therapies for IBS and their effect on global symptoms. You can see that peppermint oil and tricyclics are coming out top in this analysis based on the relative risk of remaining symptomatic, but also on the far right of the figure you can see this p-score, which is the probability that that treatment is the best treatment. So you can see the probability of peppermint oil being best is 84%. When looking at these traditional treatments for abdominal pain, you can see that tricyclic antidepressants come out top with a p-score of 0.87 or 87%. And we've also done that for treatments for IBS-D and IBS with mixed stool patterns. So these are licensed drugs for these two conditions. You can see in this network that elocitron and ramocitron, which are 5-HT3 antagonists, came out top over elaxadeline and rifaximin, and quite strikingly the p-scores here were close to 95% for most of the analyses for elocitron or ramocitron. And finally, we've also done this for licensed therapies for constipation predominant IBS, so what we call secretagogues, linaclotide, tenapanor, lubiprostone and plecanatide. Here the difference between treatments in terms of relative risks and p-scores is slightly less marked than in the analysis I showed you on the previous slide, but you can see that linaclotide comes out top for all of these analyses. So that's a general overview of the research that our group has done over the last few years. We've done some more recent papers looking at networks of psychological therapies, and also we've validated the Rome 4 criteria for IBS within the last 12 months, but I've not presented that data here. I'm grateful for the opportunity to present this, and I'd like to thank the Aldo Torsoli Foundation and the Rome Foundation for selecting me for this prize.